All right, so rationing, what does rationing mean? That's the death panels, that's all that thing. Now, if you think about Michael Porter, he's not saying ration healthcare. What he's saying is you change the incentives, so rationing becomes just the obvious thing to do. You're looking at the outcomes versus the costs. So if knee surgeries are not improving the health of the patient, but cost a lot more than rehabilitation, then the system is encouraged or incentivized to do that. So you don't have to ration because the incentives are correct. But that still says that's a lot easier said than done. All right, so he brings up the LASIK and the cosmetic surgery example. The real price of LASIK fell 30%. Why did LASIK and cosmetic procedures become more affordable? Consumer demand. What does first party payment mean? What does that mean? That means without what? First party means you pay for it, right? The consumer pays for it, not the insurance. Over the same period, LASIK and the time period they became cheaper. Prices of medical services covered by insurers rose at 2 to 3 times the rate of inflation. Here's an example of IBM and CVS getting together. Information from patients with chronic diseases that collected account from more than 80% of healthcare spending. So millions of people may one day be able to sit in a kiosk, use a computer to quickly assess the accuracy of medical diagnosis, the desirability of recommended prescriptions, and availability of alternatives. We'll see if AI is going to save us, if Costco and CVS and Walgreens are going to save us. We'll see if that's actually going to happen. The medical profession has kept a number of doctors artificially. So one of the things I have on my problems is a lack of doctors. Here's a good quote that you could put into that section. The medical profession has kept the number of doctors artificially low by preventing new medical schools from opening and limiting the number of graduates. This induced shortage makes doctors wealthier than they would otherwise be, but the shortage of physicians may also mean patients wait to be treated. Now you got to add something on other. Here's something that's really easy on other. There's been a lot of debate about, you've seen the TV shows, right? The interns, they're working these ridiculously long hours, get this. And there's been people questioning if that actually gives us better doctors. Could we not get doctors through school 2 or 3 years faster with all of the stress, and there's just as good as doctors? If you research that, I think you'll find there's some arguments that the way we're training doctors is very expensive, very time consuming, very stressful, and doesn't give you a better result on the other end. I don't think those articles are that difficult to find. The medical profession, what do they think about cheaper ways to do things? They contend that retail clinics endanger patients by using simplistic decision and treatment protocols, disrupting doctor-patient relationships, overprescribing medications, fragmenting delivery. These assertions have little or no empirical support. When it comes to treating minor illnesses, retail clinics often achieve better quality scores than physicians. Retail clinics provide less costly treatment than physicians' offices or urgent care centers with no apparent adverse effect on quality. So how much does it save? We've seen these ridiculously incredible numbers before, 80% less. So one thing you're going to see over and over again is we may not be able to solve the problem, but there are some amazing easy wins out there. It may not cut our costs in half, but there's some easy wins. We could cut our costs 10%, 15% without much effort. And there's one example of that right there. So in the solutions, it's other mechanisms for providing care, whether it's clinics or medical tourism. And we'll see a medical tourism quote in here. So we've seen these before, right? 32,000 US, 4,000 in Thailand, 150,000 versus 25,000, 20,000 versus 3,500. The Cleveland Clinic, 100,000 versus 1,600. We've already seen him. Here's some numbers. I don't know if I gave you the actual numbers for the Indian approach. Their mortality rates are comparable or better than those in Britain and the US, even better than Britain. They boasted a 1.27 mortality rate and a 1% infection rate. That compares to 1.2 and 1% in the United States. The case study was comparing their mortality infection rates to those achieved not by the average US hospital, but by the best. So you say, well, his numbers are the same or slightly worse, but that's against the best hospital in the United States. So he probably does pretty well versus the average doctor. This chart is a little hard to read, but essentially what they're doing is looking at inpatient and outpatient. The dark are the cheapest in the world, and the light is the United States. Just to show you that in everything, what's not on this list, cosmetic surgery and LASIK, right? We're probably pretty competitive on those. So unfortunately, I messed up that chart with my scribbling on it. Most Americans would rather travel domestically. So this medical tourism, which is a thing, I think I mentioned in Costa Rica, they're real big on that. Come down to Costa Rica and we'll have a vacation, and then we'll operate on you, or we'll operate on you and you'll have a vacation, or maybe your family will have some fun. But some people, they don't want to leave the United States. Well, medical tourism, when you put that into the paper, it doesn't have to be outside the United States. You can have medical tourism inside the United States. It's actually possible to fly around the United States and cut your costs 20 to 45%. So don't just think you're flying to India for heart surgery. You could be flying to, I don't know, Minnesota or someplace in the United States. Now, we should look at this one. Smart Shopper, New York Times reports the Smart Shopper gives workers a list of providers in the network that rates them on basis of quality. It then provides cash incentives to use lower cost providers. Now, why do we do that instead of the insurance company telling you you have to use this provider? So consumers don't like insurance companies telling them whom to use. How do you feel about that with your auto insurance? Your auto insurance says, here's the repair shops we use, and you want to get irate about that? Say, no, I want to use my own mechanic. We're kind of used to it, right? Why does USAA say you can only use these places? Well, because they have a deal with them, they trust them, those kind of things. Why wouldn't that work? But here they're not even saying that. They're saying, hey, we can't force you to go to this shop, but we'll pay you $50 if you do. All right, that could be part of the solution. Waiting to gain their business, local providers who know that employees share in discounts may advertise. So, you know, you put in some competition and who knows what would happen. Currently, the United States accounts for 40% of pharma companies' revenues, and we're only 4 to 5% of the population. So America is subsidizing the rest of the world. So what would happen if Medicare started negotiating pharma prices? Our prices would go down. Would the rest of the world go up? Pharma would say yes, right? They got to make their cost of capital, but who knows? It'd be interesting. You know, I haven't done a study. Are pharma companies making excessive returns? You know, I should go pull those numbers and see if they have a positive economic value added versus other industries. Who knows? It's possible prices go down in the US, don't go up in the rest of the world, and farmers just make less money. Maybe they are making too much money. That would be an interesting study. About $1 trillion in fraud, waste, and abuse, but it's important to see that this game occurs only where insurance predominates. You don't see this in other places. It's only when someone else is paying the freight that consumers toss their medical bills in the trash without reviewing them. So you don't see that in retail. You don't see that in your computer sales, or there's not this massive $1 trillion in fraud. Competition has a way of destroying that, because that's $1 trillion that someone can step in and take advantage of to provide a better product at a better cost. Solving the healthcare crisis requires relying on, this is what we've been saying over and again, less on insurance, more out of our pocket. We've seen that from almost everyone giving a proposal. Doesn't matter what political party they're from, less insurance, more out of pocket. And less insurance includes what? It includes Medicare and Medicaid and the VA. Less insurance, more out of pocket. Boy, we're getting real close to the end here. Obamacare prohibits insurance companies from charging sick people more from denying current coverage on the basis of pre-existing conditions, and from charging older people more than 3 times younger people. What should that number be? So the max is 3 to 1. The actual number is 6 to 1. And I've got some typos in here. This is hard to read, but the actual ratio between senior citizens and those, this should be and those under 65, is more like 6 to 1. Those who support Obamacare are using the insurance system to do what? Take money from you guys and give it to your grandparents. This is your chance at Thanksgiving to let them know you don't appreciate that. Wait until after the turkey. But this was a big problem for President Obama. One of his people working on this said something really, really stupid. I don't know if y'all remember this. You probably weren't even paying attention at that time. You're probably middle school or something, or maybe you weren't even born. I can't keep track of the years anymore. Many people think that health insurance differently. They think it is unfair and indefensible for high-risk people to pay more than low-risk people. Y'all agree with that? If high-risk people were high-risk simply because of what they were born with, that might have an impact. But how much of that is due to lifestyle choices? I remember a lady in Congress was debating that smokers should not have to pay more for health insurance than non-smokers. And she argued that smokers had no choice in the matter. So it was an interesting argument. You might agree with that. We shouldn't charge smokers more than non-smokers because it's not their fault that they smoke. It's their cultural things, you know, whatever. It was a strange argument, I thought. I don't want to subsidize smokers. I think they should pay their fair share, but you may disagree with it. But should older people pay their fair share versus younger people? But when people talk about this, they always think old people shouldn't have to pay their fair share, but what else do they think? But young people should pay their fair share. Can you make that math work? That's mathematically impossible, right? So if someone's going to underpay, what it has to happen? Someone has to overpay, but people always forget. It's the same thing we talked last semester, and you remember we talked about credit scores, right? If you're not going to overcharge people with low, you're not going to charge people with low credit scores the right rate, then you have to overcharge people with low credit score, with good credit scores too much. There's no other way around it. These proponents across the subsidizing rarely acknowledge their objective is to what? Cause low risk people to subsidize others. Why they argue this is okay? Because low risk people are so cheap. They're so cheap that if we overcharge them, you know, instead of paying $500 a year, we'll make them pay $1,000 a year, but that's still not that much money. Okay, that's the argument. So they want you to pay $1,000 a year instead of $500 a year. Why? So that your grandparents can pay $10,000 a year instead of $15,000 a year. Your grandparents who have a $2 million retirement portfolio, they can't afford to pay that extra $5,000. That's essentially what they're arguing. Rates for people 18 to 24 have increased 45% above their actuarial price, so that those 60 to 64 can see a 13% reduction. Take this to Thanksgiving. You know, when your grandparents drive up in their Tesla, and you drive up in your Dodge Dart, they even exist anymore. And they say, yeah, but it's not fair for older people to pay that. It's like, well, you're driving the Tesla. How was mandating a price break on health insurance for this far higher income group at the expense of lower income possibly fair? Well, here's the guy, Jonathan Gruber. He got himself in so much trouble. He acknowledged that transparency about forced wealth transfer would have doomed the bill. This is what he actually said. This is what he got him in trouble. Y'all remember this, or this is way too before your time? Anybody remember this? So he said, lack of transparency. If you young people knew the Affordable Care Act was intentionally set up to force you to overpay so that senior citizens can underpay. This is what he said. Lack of transparency is a huge political advantage, and basically call it the stupidity of whom? He's talking to you guys. The stupidity of the American voter or whatever, but basically that was really, really critical for getting this thing to pass. That's what your politicians think of you. This isn't a politician, this is a consultant, but had a major influence. He's basically saying, we're going to overcharge young people, so we undercharge old people, and we're going to do it in such a convoluted way that you guys will be too stupid to know you're getting ripped off. That got him in a lot of trouble. Got President Obama in a lot of trouble too. He had kind of distanced himself. It should now be clear that both Medicare and Medicaid are hodgepodges of three different things: insurance, prepayment plans, welfare. Medicare, this is welfare component, is a reverse Robin Hood scheme because it funnels resources from the less well off to the more well off. That's why Obamacare had an individual mandate coupled with a tax penalty. Because how in the world are we going to get you young people to overpay 45% for your health care? You do it at, at a point of gun, right? You don't do it, you're going to jail. We're going to put, or we're going to penalize you. We're going to make you, we're going to do whatever we can. Now, the problem was the penalties they charged didn't match the subsidy you're paying. So a lot of young people said, you know what? I just won't buy insurance and I'll pay the penalty. Why not? Now they've taken the penalty away. So, that cross subsidy is not as strong as it was. Cross subsidies are hard to maintain when people can avoid being overcharged for insurance. So what are the politicians saying? You young people, you guys are so stupid for not buying health care. You need, health insurance. You don't understand how this thing works. What are they really saying? Boy, we need your money. We got these senior citizens, they vote. They want their premiums as low as possible. We need you guys to overpay by 45% because we got to pay them off. That's what they really were saying, but they didn't tell you that. They told you how stupid you were for not buying insurance. Although the U.S. now spends an average more than $10,000 per person on medical service, most of the spending is concentrated in a small fraction of the population. I have a typo there. This is not accounts, but accounts. The lowest spending half accounts for only 3% of the nation's total health bill. The 5% account for over 50%. It's one of those, a small piece accounts for a massive part of the spending. Boy, I'm making y'all really cynical, aren't I? I think you should be. I think y'all should be. I really think y'all should be really angry about this because this is how politicians act. They pay the people that vote and they take advantage of people who don't. It would be hard to improve Obamacare, which requires everyone. And what he's talking about, improving Obamacare in these ways, which requires everyone to have comprehensive insurance backed up with huge amounts of federal funding to hide from everyone involved the true cost of running prepayment welfare programs in the guise of an insurance program. They talk about it like it's insurance, but they're hiding welfare, they're hiding prepayment in the system and trying to get people not to know all this stuff's going on. So if you're going to get to work, you have to have this three-legged stool, and we've seen this over and over and over again. A catastrophic coverage for insurance, out of pocket for everything else, and government welfare for those who can't afford. We've seen that from the left, we've seen that from the right, just over and over again. The ratio of federal benefits to the old versus the young is 3 to 1. A fair ratio would be 1 to 3. So I don't know how old this guy is. I don't think he's in your age group. I think he's closer to my age group. So he's kind of arguing against himself. I'm happy with this because I'm retired. Y'all guys want to keep subsidizing me, I'm fairly wealthy. So, keep subsidizing me. All right, is there a solution? So on the solution, Singapore is often put as a solution. So if you need something in the other, go research Singapore, see what they actually do. They require residents not to buy insurance, but to put money into a medical savings account. Funds can be withdrawn only to pay for healthcare. The spending rules require them to pay out of pocket for most of their medical. To encourage thrift, the law also allows them to bequeath any funds left in their account at death to their heirs. They provide for their poor citizens by topping up their medical save accounts. So they have these medical savings accounts, these MSAs. You must contribute to it. If you're poor, the government will help subsidize that. Most of what you're going to pay is going to come out of pocket, but out of pocket includes paying out of your own MetaSave account. So you're spending your own money. Medicare is an unfunded pay-as-you-go system whose survival depends on the never-ending inflow of new tax dollars. MetaSave, the Singapore system, is fully funded at all times, privately owned, controlled, and resistant to government interference. By switching to a program designed along the lines of MetaSave, Americans would eliminate both the political corruption of medicine and the medical corruption of politics. So we've seen here separate healthcare and health insurance from the employer. He's arguing separate healthcare and health insurance from the government. Now you might say, how can we possibly afford to do that? Well, are you giving any money already to this? You're already paying. What is Social Security up to now? I don't think most Americans really think about how much they give to Social Security. Medicare, so it's 6.2. What is Medicare? 145. So 765. So what are you paying? 765 times 2, you're paying over 15% of your income right now. Right off the top. How much does your itemized deduction reduce that? 0. This just comes right off the top, right? Now your 401k plan is protected from that, right? So 401k is not taxed on that. So you do have some shielding, but this is a 15% tax that everybody pays. It's capped for the wealthiest, but only Social Security is capped for the wealthiest, but that's because the benefits of Social Security are capped. Medicare is not capped for the wealthiest. So that goes in that full 145. So that is a hefty little number. This can come right off your paycheck. If you're making $100,000 a year, you're putting $15,000 into this on top of the health insurance you're also buying. So for me, you know, that's if I add all that up, we're talking $25,000 or so kind of money. I mean, it's just a massive amount. Oh, I went to the wrong spot. So what he's saying is, hey, we already got this money. Well, instead of giving it to Social Security and Medicare, let's put it in these MSA accounts. What's the one thing no one's addressing is that Medicare is bankrupt, and you're going to have the money's going to come from somewhere. You're going to have to do something for these people that are already retired. In the opinion of Main Street health policy advisors, access to medical service matters more than any other goods and services that affect people's well-being and could be bought with the same dollars. Healthcare does not equal well-being. This gets back to that second article. There's more to our health and to our well-being than just things that hospitals and doctors and pharmacies do. So give us the money and let us spend it. Medicaid is paternalistic. If the program were actually devoted to well-being, it would just give the cash away. Here's your cash. Instead of giving them Medicaid, instead of giving them food stamps, instead of giving them housing allotments, instead of giving them public education, just give them the money and let them decide how to spend it. But if the program were actually voted to that, they would give them cash, let them spend the money from their perspective. But that doesn't work. Why? They want poor people to have what they think the poor need, not what the poor people think they might want. By giving benefits in kind rather than cash, the state expresses the opinion that recipients cannot be trusted. But what else does it mean? What does in kind mean? You got to have this massive government bureaucracy to keep track of all of that. So I don't know. I'm not saying this is a solution, but a lot of economists, this is a pretty strong opinion of economists. Give cash, not in kind. And what are politicians going to say? Oh, they'll go out and they'll buy cigarettes and buy alcohol. So what are they actually doing? They're trading their food stamps so they can go buy cigarettes and alcohol, right? I mean, people are going to get what they want. So economists say, just give them the cash. And there are some countries trying this. I think India is doing something like this right now, where they're giving people just transferring cash and see how it works. Every time it's been tried, it's been pretty amazing how much more efficient. It's a lot easier just to give people cash in their account. We tried it this last year, didn't we, in the United States? Give everybody $1,200. Did the government tell you how to spend that money? They just gave it to you. So, you know, that is an argument you can make. Let's eliminate the entire system and let's just hand the cash out, let people spend the money how they think is best. Are there some people that are going to do really stupid things? Yeah, but the majority of people are going to do much smarter things than the in-kind transfer. That's the argument. The majority of people are going to actually make decisions that are in their best interests. There's a minority that won't. You let them do whatever they're going to do. Studies that show that if you do that, you're not actually going to, the in-kind forces people to use healthcare they really wouldn't use otherwise. And so people argue, well, if you didn't do that, if you didn't force them to use healthcare, they're going to be less healthy. And this part of the book says no. Actually, when you don't force people to use healthcare they don't want, you don't incentivize them to overuse, they're actually healthier. So this study found that people who cut back on medical treatments were less healthy than those who got everything the doctor ordered for free. It did not find that. Did not find that. To the contrary, it found that even though people who were treated for free used more medical treatments, their health was effectively the same as the people who had to pay. So when the government says, hey, we're going to give you Medicaid, go use the services, when the government instead says give you money and now they don't use the service, that argument that, hey, they're going to be less healthy, they're going to be coming into the doctor too late, we're going to have these major surgeries, the data doesn't support that. Oh, last page, we're almost there. Giving away healthcare for free has enormous downsides to it. It encourages people to use treatments that are ineffective, harmful, wasteful, and to rely on intensive medical treatments to cure what ails them instead of doing other things that would be cheaper, more efficacious. Boy, I love that word, but I can't say it. Like exercising, dieting, sleeping more. I mean, is it possible that the government giving us all this healthcare is actually causing people to say, you know what, I might as well do that instead of exercising? Is that possible? I have trouble with that argument still because it's your one body for your entire life. To make medical treatments free also diverts enormous amounts of money from other public health priorities. So we're back to the second article. And then the final consumerist quote, when hundreds of millions of people spend their own money on healthcare, they will behave differently and healthcare providers will too. I love this book. I do highly recommend it. Buy it and take it with you Thanksgiving and hand it, as a gift to those people who want you to subsidize them. All right, there's a lot in this book. Boy, hopefully you're keeping up with me. Sorry there weren't page numbers. For stuff like this, on your reference, you can just use healthcare book notes highlighted or something, whatever I called it in Blackboard, you can use that term. You will need to get the page numbers. Sorry I didn't put the page numbers in there. But do give me the page number that you got the quote from, not necessarily, if you give me the page number from the book, that'd be fine as well. So, unfortunately, this book is not on Audible, so you can't listen to it while you're exercising. You have to actually read the book. So that's kind of the downside of it. I'm glad people are writing books like this, that we have, people kind of pushing the envelope. But to me, going through all this article after article, books, listening to the video, to me, it's the amazing thing of the same themes keep coming back. So I'm not pushing those solutions. And it's not like I just went and looked for the stuff I agree with. I brought in a lot of stuff here. So what are the bottom lines that we're saying? Less what? What are they? See if anyone's been listening to it. I know it's 9 o'clock. We're going to reduce what? Someone yell one out. Insurance. Less insurance. So go the first party payments instead. What else we want less of, according to what we've been reading here? Right on the chat. Well, less cost, yeah, but less government. So that's the goal. But I'm talking parties here. But I agree, less cost is definitely what we want. Less government. What else do we want less of? Government can include a couple of things there. So government is provider, but what else? Provider, insurer, but what else? What's that big piece that I say is so important here? Tax rates. Yeah, incentivizer. Tax law. Less of the government involved there. I don't know how to spell incentivizer. I don't think it's a word. So what else less of? You get your first job, what's you going to be hit with? Yeah, employers. That's something this book that is extremely right, libertarian, and the guy whose last name is Emanuel, who's not Rahm Emanuel, who was the advisor to President Obama, both sides agree. We don't need health care provided by the employer. Why would you buy health insurance from your employer or get it from your employer? You don't get anything. You don't get your groceries from the employer. You don't buy your cars from your employer. Why would you do that? Anything else y'all can think less of? So treatment, yeah, less treatment. We actually want to use, aren't we saying less healthcare? Aren't we saying we're overusing the system, and the overuse doesn't show it's making us any healthier? So less treatment. Any other less? Okay, so maybe less mandates. And that can be government and insure, less mandates. That works if you do this one, right? Why do governments and insurers have mandates? Is because you're only covering $50, so you don't have much incentive. If we change the incentives, there's no reason for a mandate. What do we want more of? Some of it's just the opposite of these. So if we're going to use less insurance, what do we want more of? Out of pocket? Oh, transparency. So transparency on what? I think this is what whoever was on the chat, I forget who said that. Was that Cameron or Desiree? So transparency on cost, quality, right? So I think ultimately getting down, they're saying more consumerism. So that's what we're trying to create, right? So we're seeing these, I don't know if it's 100%, there's probably a few of them that aren't in this category. I'm not saying you have to have this solution. I'm just saying the bulk of the research that you're getting is that mainly because that's outside of Congress, that's what you're hearing most people are talking about. I want to walk through a few of these. This is going through here. There's a few quotes I didn't finish. Some of this is going to be redundant, but there's a few of them that are in here that I didn't cover. So healthcare is the ultimate consumer group good. We just saw that at the very end of that previous. It's this idea the government says, wow, we've got to get healthcare to consumers, and they need to change that we got to get health to Americans. We got to make Americans healthier, or have their but it's not health care. So I actually kind of disagree with this a little bit. It's not healthcare is the ultimate consumer good. Health is the ultimate consumer good. So I kind of not stated that correctly. I also have come back on this based on some of the articles, that book we just read, that it is inelastic in the sense that people are willing to do quite a bit to become healthy again. But what that book showed is, yeah, it's inelastic, but at the same time, consumers will shop around. If it's coming out of pocket, they will shop around. They're willing to spend some time, even though it might be really critical to their health, spend some time looking at quality and cost, and they actually will change the decision. So ultimately, it's okay if demand is inelastic, as long as there's a lot of competition there and consumers can actually say, okay, I'm going to buy something and I'm willing to pay a lot. However, if I can get it cheaper and better, I'm going to get it cheaper and better. So from that standpoint, it's not inelastic. It does require a live person, but even that's starting to change, right? We saw that with AI, and we're online, and so. But this is a very unproductive industry. Other industries, I was looking at agriculture. Agriculture used to be 96% of our economy. It's 2% today. What happened to these 94% people? Where did they go? Are they all, is our unemployment rate 94%? What do we do with all those people? So productivity is a wonderful thing, right? That 94% are doing what? They're giving us a bunch of other high quality services and products, and they're making our lives so much better. I remember I was reading the articles and letters of Thomas Jefferson. Thomas Jefferson said, if the US ever becomes a country that's not predominantly agriculture, we're done for. I'd love to bring them back to life and say, hey, you know, we're not what you thought. We seem to be doing okay. But his thought was, if we're not hands in the dirt, that kind of people, or we're not going to be a good country. So I could give you other numbers. There's some great numbers I saw in the steel industry, how much steel we're producing versus the number of people producing today versus in the 70s. And it's just phenomenal. I was reading an article in The Economist on these vertical farms. Have y'all seen that? Some amazing stuff. People cooking, I mean, growing food downtown New York City, and it's just amazing. So that's what we want. We're just not seeing that in healthcare. You're definitely going to talk about this, the insurable event. That's that very, very first article, but the other articles addressed it. You want to talk about the players and incentives. So that's going to be a big part of your introduction. Technology is both part of the solution and the problem. Technology is part of the problem is when the incentive is to treat people, technology is trying to find stuff. These minutia things that are going to be treated when they don't really need to be treated. That's technology is part of the problem, but technology part of the solution is electronic records. It's doing things more efficiently with AI, those type of things. We've talked about that one. We've already talked about that one just on the first exam. Insurance is a bad solution to anything because as soon as you use insurance, you're increasing your costs 25–30%. So we only want to use insurance for those low frequency, high severity events because it's in a very expensive model. I know some of you are part of that model, right? Your actuary majors, you want to make all that money. Actuaries are paid very, very well for good reasons, but we don't want to overuse them. We need to use them in very special cases. And actuaries are actually not all that valuable for high frequency, low severity events. That's not something they're really built to do. Actuaries are made for tail events. That's how they're trained. That's how they study. So we're kind of using them. Overdiagnosis is a big part of your paper. That's why it has so many points assigned to it. So I had this quote. Now in this part, there's some quotes that I forgot to tell you where they're from. So if you're going to use something here, just say from class notes. All right. I just forgot to bring over. I got really excited about it, put it in there, forgot to go back. So this one quote, I think actually comes from a video. Do we have an epidemic of disease or an epidemic of diagnosis? That's a great quote. Your great-grandparents, they only went to the doctor when they were sick. The last several years, we're like, you go to the doctor once a year, whether you're sick or not. That's people in the 1800s, like, wait, why are you going to the doctor? Oh, I just want him to look at me and just see if everything's okay. It's like, but you're not sick? No, they would think there's something wrong with you. Why are you doing that? Now we go to the doctor frequently. The argument there is pay me now or pay me later, but we also see, you know, that's going to cause them to find stuff that really is not going to help you. Over screening, you can find some stuff in here. If people go with no symptoms for screening, they're going to find stuff. Do you want someone operating on your back if you don't have back pain and have serious issues? I sure don't want them. We talked about mammograms. 2,000 women go for a mammogram. 1 death will be prevented. 2 will have major surgery and not need it. 5 to 15 will have early detection but die anyway. 250 to 500 will be given a false alarm. Lifter sells a medication that helps 1 out of 100 people taking the medication. It's over $100 a month per person. We talked about this. People say that screening has saved my life, but we really don't know it. Antidote is a substitute for data a lot of times. Here's one we haven't talked about, but this is probably one of the articles, but the threshold they're using for when people need to be treated for cholesterol, hypertension, the PSA scores, obesity levels keep coming down. And every time I go to my doctor, he says, oh, now you're overweight. It's like, what? I wasn't overweight last time. Well, they're classifying it lower. It's like, man, eventually it's going to be, I'm going to be weigh 20 pounds not to be overweight. It's kind of getting crazy. But why does the office, the federal government body that assigns obesity measures, why do they keep reducing the standards? Because their incentive is to classify as obese so they get more tax dollars, right? The incentives are all wrong. They keep reducing these standards. Now they have not only hypertension, but now we have pre-hypertension. Now we have pre-diabetes. And guess what they discovered? Classifying people as pre-diabetes has had no impact on diabetes deaths and conditions. You know, it creates a lot of extra costs. Often better to monitor than to treat. Experts pushing for lower thresholds are overwhelmingly in some way being paid by the pharmaceutical industry. So the goal is not to find more cancers, it's to save more lives. Poor medical quality, we've talked a lot about that. Malpractice, you can read through there. Excessive regulation, we haven't talked about that, but that last book gave you some sense of the mandates from government that can cause. We talked about President Obama saying insurance has to cover checkups now. Is that really what you want? American lifestyles. This is from the movie Escape Fire. We don't have a healthcare system. We have a disease management system. We talked about this. What makes more sense for someone who's 55, overweight, smoking, all these kind of stuff? Probably the most logical thing for them to do is stop smoking, start exercising, eat better. We know that's the solution. Some other quotes you can see in there. Diabetes, this one's pretty cool. Diabetes could be cut in half. And this is amazing to me. By a 5 to 10% reduction in weight and walking 30 minutes a day. So this I don't understand. If someone has diabetes, why wouldn't they do that? I don't get that. I know losing weight is not easy. And our country doesn't, you know, these lawsuits against McDonald's and all that, you know, I understand it, that our country makes it so easy to not eat right. But this is your body, right? This is what you're stuck with the rest of your life. It doesn't take much. Drugs reduce diabetes risk by 31%, exercise reduces it by 58%, and by 71% by those over 60. So I'm curious in your paper, how do you get people to do this? And I'm to the point of, if that's not enough to get them to do it, I don't know if any monetary solution is there to get them to do it. I understand on the first one, losing weight is really, really difficult, but walking 30 minutes a day, that's not all that difficult to do, right? Just get your iPhone with the counter of steps and you got it, right? It's not that difficult. We talked about safer already. 70% of the baby boomers, or 70% of healthcare costs are concentrated in diabetes, heart failure, coronary disease, asthma, and depression. Americans over 60, 76% take 2 drugs, 37% take 5 drugs. Americans over 65, more than 50% have 5 or more chronic conditions. That's why they said it's 6 to 1, older people versus younger people. And I bet anything, well, this gets me in trouble, but that's 6 to 1. I bet a lot of that one is maternity, because that's usually for young people, the most expensive thing they do is having a baby, right? So, which I'm fine with. I don't mind insurance covering that. I'm not anti-baby. 1/3 of people who die have major surgery in the last year of life. 15% of terminally ill men have very unnecessary and painful prostate screening. End of life issues, we've talked about that. Growing shortage of doctors, we got a good quote on that. Complexity of the system, inconsistent cost. There's some interesting data here. I don't think we covered anywhere else. One survey of deaths from heart surgery ranged from 1% to 18%. Would you like to know that before you go in to get operated on? Reporting the data to the public caused almost immediate improvement, 41% reduction in deaths in a year. by doing nothing more than reporting this quality data. But hospitals fight that. Here's that smart shopper. Let's see what their website looks like. Again, this is something you could get for your 5% by just doing a little research on that. Oh, wait, we got people in chat. Sorry, you on the chat. I'm not very good at looking at chat, so I'll try to look at it real quick. Oh, you are answering those questions. More quality, quick care. That's a good one, Desiree. That's kind of what we're getting to here. Quality care at a lower cost. It pays to shop. So that's an interesting thing for healthcare, isn't it? Because you're talking about insurance. Why would it pay to shop if my insurance is going to cover it? Well, we're actually going to pay you money if you'll shop around. Start now. Well, what do they have there? MRI, 3,000, MRI 1,500. Which would you do? The insurance would cover the 3,000, or the insurance covers 1,500 and they'll pay you 150 bucks. But this is 10 miles further away. Would that be enough? Would you drive an extra 15 minutes for 150 bucks? So they're going to ask for your zip code, and that might tell you whether it works or not. How many Americans know this exists? Probably very, very few. I don't know if you're in the system, but so one of you for the 5% or whatever the extra credit is, I can't remember. Just go in the system, sign up, and see if it works in San Antonio, what insurance you have to be under. Give me a good discussion of this because I'd be really curious. You can save me time. That would be an easy way to get some of those extra points. Inefficiency is encouraged. Inefficiency and errors are encouraged. Supply creates its own demand. I think I took that out of the rubric actually. Government focus on price over cost. We saw that in that second article. Many see healthcare and health insurance as the same thing. There's a quote in one of the articles I saw that it was so ridiculous. Highest driver of healthcare costs is the rising insurance premiums. I mean, that makes no sense. An actuary would see that and say, wait, who wrote that? And when did they get out of the second grade? I mean, that makes no logical sense. What should it say? The driving of health insurance premiums is what? Higher healthcare costs. What does insurance do? It's a cost plus model. It's cost plus profit plus expenses. If healthcare costs go up, health insurance premiums go up. That sentence makes no sense at all. You need to talk pre-existing conditions, uninsured Americans, but these are the two easiest ones of all. I have students that leave this out of their paper and it's like, just talk about it. I give you a lot of credit if you don't even give me the numbers. But it's easy to get the numbers, and in the articles, you just do a search on pre-existing conditions. Actually, there's no numbers on pre-existing conditions. You just talk about that issue. So what is pre-existing conditions? People buy insurance and the insurance says we can't cover any conditions you already have. The Affordable Care Act takes that away. So how do you handle pre-existing? You just make it illegal to price that. We talk about healthcare costs for women versus men. You can put that under the problem or under solution. I think of it better under solution because the solutions are more out of pocket, and so it's always going to hurt women more, but you know, you can talk about other insurance. Bad processes, the need for Six Sigma kind of analysis, lack of data for comparing costs, treatments, quality, and in Michael Porter's paper. Let me see if there's anything else in here. There's a few things. Oh, on quality. I can't remember if we talked about this, but I don't think we did. What do we mean by quality? So bounce back rates, people who go in for a treatment and then they have to come back 30, 60, 90 days later with some complication. The mortality rate, the never event rate. I think Michael Porter had some of this stuff in his, but this is a little bit different list. So the never event rate, those things that should never happen, a sponge being left in the patient. Y'all probably seen this on TV, right? There's one sponge missing. We can't find it. Where is it? Is it still in the body? You know, that kind of thing. Operate on the wrong patient or operate on the wrong side of the patient. Can y'all believe that hospitals amputate the wrong leg sometime by accident? Oh. Oh, no. Well, hopefully he would be awake that could kind of tell them that. That would have been pretty funny, not funny, if he walked out with a cast on his leg. Death following elective surgery. That should never happen. Infection rates. What is your hospital's infection rates? There's surveys. This is the thing I really think they should put out there. Culture survey scores. Just asking nurses, would you have surgery in your own hospital? Nurses are very honest and they know what's going on, and they're the ones I want to hear from. I want to hear from them more than doctors. I think doctors have kind of a prima donna sometimes. Volume of treatments. How many times have they done this? You want as much experience as possible. The percentage of doctors that use less invasive techniques. So this is a good example. We had the Iraq, and during Jimmy Carter's time, we had the hostage taking. Y'all may not remember any of that. The Shah toppled. Why did that happen? Because a doctor operated on the Shah of Iran, and there was a much easier, less invasive treatment they could have given him, but this doctor didn't know what he's doing. He ended up causing the entire Iran hostage taking. You should read that story. It's pretty interesting. The Shah should have not been taken out. Use electronic records, open notes, video recording. I've seen some doctors that do more of this. I have doctors that are old-fashioned handwriting. I've seen more and more than my hand doctor. I had a hand doctor when I dislocated my finger. Everything was recorded and just went into the system. Process improvements. A big chunk of the doctors is just keeping up with the claims management process. There's ways to automate that. You can read some of these quotes. We tend to overuse the system, so you get some good quotes there. Evidence-based medicine we talked about. Does fixed salaries for doctors really solve anything? And I think what Michael Porter and what the studies have shown, even with fixed rates, you might say, well, that doesn't incentivize a doctor to do things, but it doesn't fix the system. Until you incentivize doctors to make us healthy, you're not going to fix the problem. So that's fixed salary essentially says we don't care anymore. They almost want to treat us less often if they're fixed salary, and then we're undertreated. I had something in here about washing hands that I want to show you, but I don't find it here. Where did I must have taken that out. The handshake's not in. I'm going to show you the handshake later. Boy, let me try the word wash. I must have taken that out. It was a really amazing. There it is. Why didn't that find hands? All right, so here is, use of video records. I don't know why that's under, I guess this is video records, not to record conversations with doctors, but actually record doctors and doing their job. All right, so this is an incredible quote. One survey showed that before video was used, only 6.5% of doctors washed their hands before surgery. After the use of video, this rose to more than 90%. That's just a freaky quote. You would just assume all doctors wash their hands, but there are some doctors who just don't think they have germs because they're prima donnas, So that's why I asked my doctor if he was going to wash his hands before the surgery. He probably didn't just because he hated that question. All right, so there's some stuff in there, not much. I think we've covered most of it already. So it's an amazing problem. It's a complicated problem. And the advantage you have is you don't have to fix it. You just have to propose what you would do. All right, so a few other notes just real quickly. This is a skewed system. 1/3 of people submit no claims in a year, 10% submit 2/3 of the claims. The percentage of premiums that go toward healthcare services. So this medical loss ratio, and it dictates a minimum of 85% for large groups and 80% for small groups. But what that means is 85% of your premiums have to go back to you as a patient. So it has to go on the claims. Only 15% can be for the insurance company's expenses and profit. However, insurance companies have found ways to get around this. There's actually a pretty good article in there, I think I gave you, but I didn't highlight much, how insurance companies have figured out how to reallocate what they do so that more of it goes into 80 and 85%. But still, with 80%, what is the insurance company doing? It's raising your costs by 20% or 25%, right? Because 20% of 80% is 25%. So anytime insurance touches it, even with the new law, insurance is automatically making costs go up 25%. Here it is, Ezekiel. I found his name. So here's his book, Reinventing America Healthcare. So he was a big part of, so his brother, Rahm Emanuel, was the governor, the mayor of Chicago. Ezekiel was a big part of the President Obama's staff and the healthcare reform. So he gives some statistics in that book, private healthcare insurance through insurance companies. Now, don't be deceived by these numbers. 54% of US population is covered by private healthcare, but 54% of the expenditures is not coming from private health. The majority of the expenditures are coming from Medicare, Medicaid, and VA. Why is that? Because those are the old people, those are the sick people. So 54% of people are covered, but 70% of the expenditures are coming out of these programs. 95% of private healthcare coverage are coming from an employer, 5% individuals. What does Ezekiel want to do? He wants to take this number down to 0. He doesn't want employer provided. Employers pay 72% of premiums for families, 82% of premiums for individuals. So the employers are covering a big chunk of this. Do you think employers would love to wash their hands of this and get rid of it? I do think there is a domino effect. If a couple major employers says, we're not covering healthcare anymore for our employees. Now, probably laws are not going to let them do that. So you can get the laws that allow them to do that. But I think there are employers who would like to get away from it. 98% of employers with 200 or more employees offer health insurance, for only 50% of employers with 10 or fewer do. Tax benefits of healthcare, we already seen that. It's a huge amount. It's $250 billion versus only $70 billion for the home interest deduction. Private insurance, I'm not going to go through that, but he talks about the different types of coverage: insurance companies, Blue Cross Blue Shield, HMOs, employer plans under ERISA is it's regulated by the federal government. There is COBRA for terminated employees. Health insurance, public health insurance, 31% of the US population. You're going to find that the numbers don't add up to 100 or may even add up more than 100. Some people are actually covered twice. Medicare covers 18% of the US population. Obviously, that number is going up. It's got 4 parts, part A, B, C, and D. A covers hospital. It's funded by the payroll tax. B covers physicians' visits. I think I accidentally said B was President Bush. Actually, I think D is President Bush. Covers physician visits and other non-hospital services. Funded by government revenues and premiums paid by the enrollees. C is Medicare Advantage. Private insurance plans offered to Medicare eligible where U.S. government paid the premium. Part D is the prescription drugs voluntary program where eligible can enroll. Most seniors, about 90%, get their prescriptions coverage through Part C plan or another area. Funded with an income-linked premium that covers about 25% of the program cost. The federal government pays the other 75%. But they are getting your Medicare tax to help cover that. So what do senior citizens say? Well, I paid my Medicare premium my whole life, so I shouldn't have to pay for this. I'm not going to cover the donut hole, but you can look at that. People say, wow, how can these seniors pay $45, $50? Well, because they're wealthy, they have the money, they can afford to pay it. It's not that big of a number, a couple $100. People that are spending $50,000 to $100,000 a year on prescriptions can afford to pay an extra $4,000 into the system. All right, you can read the rest of those. Medicaid covers 23%. So again, some people are covered by both. It's a means tested program, joint federal and state program. I think President Biden's thinking about forcing states like Texas to expand Medicaid. I think I saw that in part of their last proposal. It does vary state by state. The federal government pays about 57% of the program costs, and it's disproportionately to poorer states. CHIPS program, you've heard some about the CHIPS program for children up to age 19. The VA is interesting. I know a lot of military people who are like, we can't have this socialized medicine. Well, where's our most socialized medicine in the United States? It's the VA, right? Everything's covered. It's insurance, it's healthcare, it's everything. It's the most socialized program we have. And uninsured, I say 15%. The Affordable Care Act has actually had a tremendous impact on uninsured and has brought that number down. I don't know what it is today. You can look it up and get that number. But yeah, the Affordable Care Act, the problem with that is we got a bunch more people into the system, into a very, very broken system, but at least we don't have uninsured Americans, but we have insured Americans in a really, really bad program. Who are the uninsured? The working poor, definitely, the unemployed, but there are a lot of higher income people who simply choose not to be insured. That's just what they want to do. I'm not going to cover the Affordable Care Act, but if you're interested in some of that, you can read some of that. Here's some other sources. We talked about the Gold Hill. I think his article covers it pretty well. Overdiagnosed, that was a good book. That was the whole book is about overdiagnosis. Code Red, How to Solve the Healthcare Price Crisis. Here's a book. No, that's the article. The Creative Destruction of Medicare, Reengineering Healthcare, Money in Medicine. I don't think, well, this might still work. Escape Fire, that was a movie. I didn't like that movie too much. You might try it out if you really want to get into that. I didn't think they did a good job. There is supposedly an ongoing discussion about this. I don't know if it's still there. Another good book. I go out to Amazon.com and to Audible.com every year looking for newer books on healthcare. They've kind of dried up. We haven't seen one in a while. So if I can find another good one, I'll bring it in and bring in some of that data. But there was a lot of books written around the Affordable Care Act, obviously. And so, they were writing them because they could sell them. And recently that hasn't been as big of an issue. All right, so I'm about to send you out into the paper 2. Can y'all handle it? What percentage of your paper you've already got written? This really is a paper. If you got your quotes, you can sit there and write off the top of your head just going through the rubric. It really is one of those type of papers if you've been collecting your quotes as we go. If you haven't, you're gonna have to do everything we just done the last 5 classes all over again on your own. So hopefully you've been collecting data as you go. I see some of y'all frantically keeping up with me, so I know you're doing it. All right, it's a tough paper. I will, maybe next class I'll show you an example paper from a student. I wish I could show you a really good one and really bad one. I don't know how to get away with that, especially maybe if I turn the video off and show you a really bad one. But I will show you a really, really good one so you can see, the format. And there are a lot of students that their titles are just what are the rubric is. Now, it's not a homework assignment. You're not, I want you to write it as a professional paper. But if you want to use my rubric, you can. I would reorder it in a few places if I were you. But if you want to make sure you've covered everything by doing that as a start and then reorganize it later, that I have no trouble with that. I won't count off if you do that. You all know where the rubric is, right? So make sure you have that. If you get to the rubric and it's like, what in the world does he mean by that? Then call me and I'll tell you what I meant by that. All right, don't waste 3 hours trying to figure out what the professor means. Just call me and I'll tell you. All right, I'm gonna let that a little early. Next class, we'll finish up a few final products. And then definitely next class, get ready for the calculator. I think we'll start. Oh yeah, we're gonna retake exam question 3. Next Tuesday, we'll stop right about 10 o'clock. And anybody wants to retake that question, we'll do that at 10 next week. So it's be kind of late. It only takes about 30 minutes to finish it anyway, so we'll do that next Tuesday night. All right. Let's cover a few last little problems and products for this industry. And we'll get into the issue of, or the concept of a group product. Disability insurance is a fairly specific industry, a product that is really limited to a certain number of people. Not a whole lot of people buy this. A lot more people buy life insurance, or obviously a lot more buy health insurance than disability. It doesn't mean it's not important. It's an extremely important insurance, but most of us are going to get this from our employer. It's just part of our employment, and we won't buy a separate product. But it provides income to you if you become injured or you become ill and you can't go to work for an extended period of time. We'll talk about when it may kick in. Most of it is group, but you can buy individual products. Y'all know the most famous company for this, right? You probably see there, the duck, right? One thing that's always bothered me about Aflac is watching their commercial. I don't think anybody knows what they actually sell. Do y'all know what they sell watching their commercials?
Sure, disability.
Yes, disability. So, but do you know that from the commercials? When I watch the commercials, I'm like, oh, they're going to make me happier, and my life's going to be so much better. Wow, that's really great. Wait, how are they going to do that? Are they selling coffee or what? So, so short-term disability, critical care and recovery, supplemental coverage. So, yeah, that's the main thing it does. What a duck has to do with that, I don't know. But it is a fairly concentrated business. There are a few players that provide the most of it, and that's mainly because employers provide most of this. Employers might buy this from an insurance company to help cover them for it, or they might self-insure. We also, in my P&C class, we talked about workers' comp. Isn't workers' comp the same thing, essentially? What's the difference between disability income and workers' comp? Well, workers' comp is you get injured on the job. Disability doesn't cover that. That's the thing it's always going to include. In fact, if you call in with a disability claim, that's probably the first question you're going to ask. Were you injured on the job? And if you say yes, and it's click, we can't help you. Go to your workers' comp. All right, so provides income if you're injured. What group insurance wants is that the people who are buying the insurance is just incidental to what they're doing. They don't want to sell group insurance to a group that got together just to get the insurance. That would not be good, because who's going to get into that group? All the people with high risk that have a need for it. So adverse selection, anti-selection is a huge issue for disability, mainly because there's a lot of people that would rather sit at home watching TV and getting paid and not working. There's a lot of jobs, and I can't blame them. There's some jobs, I don't think I could do them. I worked for Chick-fil-A for a week and McDonald's for a month, and that's about 5 weeks longer than I can take. So yeah, those are tough jobs. I don't know if y'all do fast food, but it's not a fun job to do that for year after year after year. I can understand why those people switch so often. Just have a different environment. It would make a lot of sense. But those type of jobs tend not to be offered disability insurance. It tends to be more professionals. And I doubt McDonald's has a disability program at all for their hourly workers. So group must be large enough so that it doesn't get devastated by one large claim. That's true for workers' comp as well. You may actually have a greater need for disability income than you do for life insurance, because you are more likely to be injured and be out of work for an extended period during your work life than you are to die prematurely during your work life. But the difference is, when you die, that's it. You don't have any more expenses. But when you become disabled, you still got to maintain your living expenses. So you actually need probably more money, because you got to, with life insurance, you got to leave money for your heirs or to your beneficiaries. They're still there if you have disability. You still got to take care of them, but now you got to take care of yourself as well. Social Security does provide disability. My experience is well, you better be really disabled. I was working with one lady in my church that is like, Social Security just would not give her disability. I was like, how much more disabled do you have to be than this lady was? I couldn't see how she could possibly do any job, just as physically out of it as she was, but they said, no, you're not disabled. So it's not a good one to rely on. They break it between short-term and long-term, and it gets a little confusing on the short-term, where short-term stops versus your paid time off and your sick leave and those kind of things. A lot of firms coordinate those two, so you don't really notice the difference, but long-term disability is its own thing, and it's really, really critical. A lot of times it will stop paying at age 65. That can be an issue if you got some chronic things going on, you have expenses. I think the dangerous thing is if you're on disability and you're gonna live a long time, you're getting your expenses paid, and then it stops at 65. And were you saving for retirement during all that time? You're just assuming, hey, I'm not working, I don't need to save for retirement. You could find yourself in a lot of trouble. But it does have a huge moral hazard. People actually violating the law and filing false claims, and there's a morale hazard. A lot of people initially thought you can't offer this product. The morale hazard is just too high. People would much rather have a claim than keep working. So how do you do that? Well, first of all, you don't give them 100% of the pay. You give them 60 to 70. Part of this is because disability income is tax advantaged. So you got to make sure you don't give them 100% because they'll come out ahead if you do that. But also they give less so that you're not living as well with the disability as you're living without the disability. They may require some offset with the others. So their goal is that someone making $70,000 a year doesn't go on disability, and suddenly they're making $95,000 a year. That's not going to be good. So duplicate coverage usually excluded. So they break it up by the type of jobs just because they consider professionals probably would prefer to work than just sit at home. White collar, not as good as doctors and lawyers, but still people who probably want to be at work. And then blue collar is going to be the most difficult, partly because people probably prefer not to work, but also because they're probably a little more dangerous jobs as well. What did they cover? Sickness is easier to defraud than accident, and so there can be limits on sickness, but it can be just accident only. It can be accident and sickness, where accident will cover longer. Only covers non-occupational, as we said. What more firms are doing, we'll talk a bit more about this. Actually, we won't. We talk about it more in my P&C class, but there's more coordination with these programs. Workers' comp, short-term disability, paid time off, long-term disability, coordinating them all together so that the employer and the employer worries about all that, but the employee doesn't really notice. They don't know if they're in workers' comp or long-term disability. And then the deductible is essentially how long you have to be disabled before it starts paying. So your deductible isn't an amount of money, it's an amount of time. So if you're not disabled for more than X number of weeks or days or whatever, then you're not covered. Now, she's not an issue because most people have sick leave, or we called it sick leave at USAA. I think now everybody calls it paid time off. USAA made that switch where they used to have vacation and sick leave. And then they said, you know what? Here's your paid time off. If you're sick, your paid time off. If you're vacation, that harmed me because I'd never taken sick leave. I didn't take a single day of sick leave in 23 years at USAA, so I never got the sick leave. And so when they combined them, you lost some of one and some of the others. Like, hey, I should go out sick really fast before this new program comes in. But there's other people, the claims area, where a lot of employees, they took 100% of their sick leave every single year before this new policy. And that is such a difficult job. I kind of understood it. But a lot of firms, they just coordinate this. You don't really notice. Long-term disability has a much longer waiting period, and then it kicks in. You need that waiting period just to keep the premium down, because this is something you want to make sure it's really for those people that are the most injured. So the key, if you buy one of these policies, is get the definition of disability. How do you know you're disabled? So the best was you cannot do what you were trained to do, the specific job that you were trained to do. So if you're a heart surgeon and you injure your hand and you can no longer be a heart surgeon, you're disabled. The fact that you can teach in a college, You can still be in hospital staff as a consultant. You just can't do surgery, but you're not going to make as much money. In this case, you would be disabled. The next one says you can't get a job that's consistent with your training and skills. So there's where a doctor who can't operate anymore but can teach would not be disabled because they can do something consistent with their skills. Maybe one of the most impressive people I've ever met in my life was a surgeon who injured his hand and could not do surgery. And so I met him selling emerging market portfolios. He was a portfolio manager for emerging markets. And so that's quite the career shift. Go from surgery to emerging market stock manager. So I didn't ask him if he got disability, as you know, if he was considered disabled or not. He was probably making much more money managing stocks than he was as a physician anyway. You can't do any job for which you reasonably could become qualified, or you just can't do any job at all. That's going to be the worst and the cheapest. Some are saying, you know what, let's forget about that. Let's just say you were making 80,000, you've been injured, and now you're making 50,000. So we're going to make up whatever that difference. You know, it's all about how much were you harmed. I don't know how common that is. Definition of injury, it needs to be accidental, unintended. The injury is unintended, not necessarily the action is unintended. So if someone intentionally threw the football at you and smashed you in the face, the injury is unintentional, but the football throw was intentional. Sickness usually excludes pre-existing conditions. Now here we're not talking about your health care, we're talking about your income. So you can't work because you're sick. So it's going to cover your income. Your health care will cover the health costs. But if you have pre-existing conditions, obviously they don't want people who have a condition that's going to definitely make them able to work. So they take a job just so they can go on disability. Yeah, that's what they're going to try to avoid. But group policies don't care about that. That's the wonderful thing about group policies. Has anyone ever taken advantage of that? I'm sure someone has. Because the employer says, hey, all of our employees are covered, so we're not going to worry about pre-existing conditions. There may be a waiting period, so you start your job, you can't get it for say 6 weeks or so. But once you're in there, you're covered even with a pre-existing condition because you're in the group. So yeah, I mean, if you got someone who knows they're going to be going out on disability, if they can get a good job with a good disability program, they could essentially set themselves up pretty well. I'm sure someone's done that. There's something called a waiver of premium benefit. Not that important, other than I just think it's funny the way the accountants handle it. But what they say is you got to keep paying your premiums even while you're on disability, but you don't really have the money to pay your premiums. So the insurance company will pay your premiums while you're still on disability, so your policy stays in force. That's called a waiver of premium benefit. So what the accountants have to do, I just think this is so strange. It is revenue and expense on the income statement. So if you go with disabled and your premium is $200 a month, the insurance company selling that policy has $200 of revenue they're paying themselves, and they have a $200 claim that they're paying you. There's no cash going anywhere, but they actually show that. So I don't know why they do it that way. That just seems really bizarre to me, but there's a lot of things I learned about insurance accounting that I thought, boy, no one said anything about this undergraduate in my accounting classes. You got to provide your claim within a certain number of days. Obviously, the insurer has the right to try to make sure you're getting the right rehabilitation, that you're getting the right services. If you change your occupations from a less risky to a more risky, they obviously have to know what that is. If you go less risky, they'll reduce the premium. Don't forget about your retirement savings. It's not taxable except for in certain circumstances. Usually if you personally take a tax deduction for buying the policy, you're somewhat converting it into taxable when you get the claim. So that's the thing you got to watch out for. The moral hazard, boy, I don't want to show y'all all of this. Some of these are almost cruel for me to show you, but I think it shows you the moral hazard of this. I have no idea what VRBO is, but I get their commercials all the
The
time.
United States gives over $175 billion from Social Security each
Now, this is Social Security disability, but it's the same issue for other disability.
year to those on disability. And for certain types of people, that means only one thing: money up for grabs. You're about to meet some fraudsters looking for extra cash by milking the system, and the investigators out to stop them.
Now, some of these videos are about Social Security, some of them about workers' comp, and some of them are about private disability. They're all the same fraudsters. The only difference is the workers' comp, you got to somehow have it happen at work. So if you need a vacation, then get your buddies to throw you down the escalator at work, and then you got it. If you get caught, you go to jail. So you'll be sitting in jail with the casts, but it's not legal, but people try to get away with
Here's
it.
ABC's Neil Karlinski for our series Nightline Investigates.
You're watching undercover video, a sting by federal agent.
I think that's breakfast for you, or is it after 10 o'clock?
So these two people are disabled and your tax dollars are covering them. So see if you can see what their disability
More
is.
money. A couple.
Remember, on Social Security, you almost have to be disabled so you can't do any job. What does it look like they're doing? Looks like they're doing a job, doesn't it?
And to be so disabled, they couldn't work. Or in many cases, even stand up very long.
Looks like she's getting it pretty good. And this is both of them are disabled.
As if daring someone to come and get them, the targets, owners Ramona Haynes and Corey Eglash, virtually put a sign on themselves, opening a coffee shop called Criminal Coffee, complete with the slogan, "A place to come when you're on the run." The location, one of the most out of the way.
Let me show you another one.
To defraud the government of $29.9 million. And these numbers don't even.
Right. So who do you think's disabled in this video? So here's this, let's just give you some good advice. You're committing disability fraud, don't go on The Price is Right and spin the wheel. Just a little advice.
Disability fraud, like workman's comp. This woman, Kathy Cashwell, was raking in $3,000 a month, claiming a shoulder injury left her unable to stand.
How could she be that stupid? It's just like, I think there's another one. No, it's just those two. There's a bunch of these out there. I think last semester I showed you a guy who pretended like he lost his mental capacities and he was like a 6-year-old. He had to act like that every time we went in public. I don't know if y'all remember that from last semester. It was pretty painful to look at. So if people do some crazy things, she must really hate her job, but how could she be that stupid to go on? So anyway, this is amazing. And she's all happy about it. Now you go to jail. And she should, right? She's robbing from us. So it's, you can find all kinds of these. Now, this is a little dated, but people have been asking, why is the participation rate in the United States so low? Why does it come down? Now, we know COVID's had a big impact on it. We know the baby boomers retiring, but this article says part of it is more and more people are filing disability claims. So the labor participation rate has plunged from 66 to 63, and it's still staying down, even going lower. Most economists believe much of the decline is structural, more college enrollment, baby boomers, women not, they've already joined the workforce, but that doesn't explain everything. And so here what they're looking at is the increased disability applications. More generous unemployment benefits tend to elevate participation rates since workers must be looking for work to qualify. So the participation rate is not how many people are working, but it's how many people who are working are looking for a job. So better unemployment benefits will actually raise that participation rate. But disability, the opposite applies. The qualified applicants must generally demonstrate that they cannot work. So they're not going to be in that participation rate because if they're looking for work, they're obviously not disabled. Disability and unemployment should not be correlated. From 1966 to 85, they weren't. But in 84, DI eligibility criteria were eased so the applicants could qualify based on a combination conditions rather than just one. Highly subjective conditions such as back pain, that's a really hard one to measure, right? There's no test a doctor can say, hey, your back pain is 73.2. That's, you just have to ask. Mental illness have grown to account for most disability beneficiaries, and claims have become more correlated with unemployment. That strongly suggests that many workers find a way to qualify for DI when other benefits have exhausted, and what happens, the participation rate comes down. The number of applicants shot up from 11.2 per 1,000 workers to 14. That's a pretty significant jump. This could explain between 31% to 59% of the decline in the participation rate. These results suggest that if it were not for people receiving disability, the reported unemployment rate would be higher, right? Because there would be unemployment is a number of people unemployed over the number of people looking for jobs. So if you're not looking for a job, it actually helps reduce that unemployment rate. But if you get more people that really should be that number, unemployment rate would be much higher. The proportion of working age adults on DI has risen from 1.3% to 4.6. I mean, it's amazing. The impact on participation rates may be cyclical at first and then become structural. So disability has unintended consequences, and there are people out there that just would prefer that. Those two people look like they're double dipping though, didn't it? Disability and they had their own business. I mean, that sounds pretty good. I don't know how they get away with it when filing their income taxes every year. You would hope that the IRS would notice that someone's on Social Security, disability, and having other income at the same time. You would hope they would make that connection. All right, so that's disability. Most of you will get it from your employer. I know very few people actually check that, but in the employment orientation, you might ask, what is our disability plan here? Most people don't worry about it because they just assume large employers all offer the exact same thing, but you may want to know. All right, long-term care. This is a very interesting one, mainly because we've got so many people retiring, all these baby boomers. Y'all saw that in paper one, the aging of the US population. So long-term care, we're going to see a lot of people going in nursing homes, assisted living, and that's really expensive. You're talking $5,000 to $10,000 a month. If you're Social Security and your other pensions, it's only $70,000, $80,000 a year. You're going to have a tough time covering that and having anything left over. People are living longer. You've already see this for paper two, right? We're finding how to keep people alive. They may not be living all that well, but we're keeping them alive. People are aging. And a lot of this nursing home is the last few months of life. So it may be at the very end, but for the last 6, 7, 8 months, and it's $10,000 a month, you're talking $50,000, $70,000 that suddenly need to come out of these people's pockets. Should insurance cover that? The care can be in-home or institutional. Medicare is very restrictive. Medicare does cover some long-term care, but not much. Now, remember President Obama, when they were talking about the Affordable Care Act, he initially said, we need to put long-term care into this. And then they looked at the numbers and he's like, no, we're not touching that one. That is a mess. And the main reason is people don't want to touch this is no one really knows how massive this thing could become with all these baby boomers. So it's a tough business. But Medicare is very restrictive. It's only skilled care. It has limitations on home care. It must be certified by a physician that you need it. The nursing home must be certified by Medicare, and you must have the requirements, the Medicare list for home care. You can see the restriction there. You have to be on a physician. Physicians must certify. They got to be certified by Medicare. HIPAA defines this disability is that you can't do at least 2 of those activities without substantial assistance. So very restrictive. And the issue here is, could this really blow up and affect us? So I'll show you, I think we talked about this firm earlier, but Genworth is the big firm here. This is Genworth is the long-term care firm. And you look at their stock price, it's not looking good, is it? This is a stock that used to trade for $36 and it's down to $4. It's just, this is just not a good business. If I were an actuary, I don't think I would touch this business. And a couple of reasons. First of all, we're not sure it's going to survive. It's got a lot of trouble. Secondly, though, if you became an actuary here and you learned all of this, this is such a specialized business that may not transfer over to other actuarial jobs. So I don't know if I would touch this business. There aren't that many businesses, there aren't that many players in this business. So it is very, very specialized and concentrated. So maybe, we can look at the profile of this company and see, I don't think they do much else other than that. Has mortgage life, offer long-term care products. I mean, that's its main business. So it's a tough business. I don't know actuaries if it's like long-term care actuaries and that's what they specialize in and just do. I would imagine that has to be the case. This is just very specialized. And why is it so dangerous? Well, there's a growing gap in healthcare coverage that the government provides with nothing on the private side to fix it. They give policyholders a way to reduce or eliminate limiting rate increases. So essentially you're trying to lock in. So if this assisted living jumps up in price, you've got a policy that's going to help cover that. But the industry's shrinking. So we have an industry we really, really need, and it's shrinking. The premiums are soaring, and there's no fix in sight. The government safety net programs, they're underwater, and they're underwater even before the baby boomers comes in. So that disability we just saw, and then you got long-term care, those programs are already underwater. They're already in red. Social Security and Medicare have a few more years in the green or in the black, but these programs are already receiving less taxes than they're paying out in benefits. The administration abandoned an effort to provide rural care term, including it was too expensive. So yeah, President Obama knew, hey, let's not bite off more than we can chew. We already got a pretty big monster we're dealing with here. For the most part, seniors who need care have to burn through their savings only after they are impoverished for Medicare step in and only provide the basic level of care. So it sounds pretty scary, right? You're saying, man, I don't want to put this on my family. And your family's thinking, I don't want them moving in with me. But they need assisted care, especially Alzheimer's. That's a pretty tough one to deal with people. In that case, they're going to need around-the-clock care. So it sounds like a serious problem, and the industry shrinking. Insurers unestimated how fast medical costs would rise and how many seniors would actually use the benefits. And they underpriced the premiums, making matters worse. Some insurers that were hungry for market charged too little at first and plan to increase premiums later. Only a dozen or so companies still sell meaningful numbers of policies, down from about 100. The past decade, sales to individuals have fallen by 2/3. Most of the actuarial assumptions made by insurers years ago turned out to be overly optimistic, underestimating how long elderly would live and collect benefits. As a result, led to a 14% shortfall in premiums. The insurance industry also failed to realize how desperate Americans are to protect themselves, so they cling to their policies. So the insurers are saying, "What? Hey, we got to charge more, and we got to get those really, really bad customers to quit." And they're like, "No, I'm sticking with this thing. I'm not giving up." So they kept paying the higher premiums. Most insurers predict that 5 to 7% of people who bought long-term care coverage would cancel their policies each year. Instead, the annual cancellation rate was less than 2%. Initial premiums have been about 35% higher if insurers. So this is something actuaries you're going to learn. This cancellation rate, they call it the official term. You're going to use this in an interview. It's called the lapse rate. Have you all heard that before? What does a Netflix call theirs when they lose customers? Is it just the loss rate? They have a term, don't they? Next flick, or maybe it's turnover or something. I don't know the term, but in insurance and life insurance, they call it the lapse rate. Those are the people that they lose. Now, you might say that, oh, that's bad. We want a really, really low lapse rate. But actually, the actuaries assume a certain lapse rate, and if they miss it, it can harm them whether the lapse rate is higher than they expected or lower than they expected. On some products, they actually like the lapse rate to be higher because they make so much money on the product early. On some products like life insurance, level term, they need the lapse rate to be really low because they actually lose money early and they need the product. So it depends. This is a product where a low lapse rate actually hurts the insurance company. Why? Because it's those later claims that are killing them. Genworth, with about 33% market share, I don't know what it is today. So the individual said in May that is seeking premium increases averaging 50%. So that's a pretty hefty premium increase. The insurer started requiring blood tests and other medical screening, which the industry generally hadn't done before, charging women who apply individually more than men for the first time because women tend to live longer. In general, a 55-year-old single person buying long-term care protection can expect to pay $2,000 a year for $162,000 in benefits, including, now, I don't know if that 162 is the total benefits or if that's annual. If that's annual, you know, that's going to cover, what, about 2-3 years worth of nursing care, including 3% inflation protector rider or a 20% increase from last year, according to the association. $2,000 doesn't sound much, you know, $200 a month. But you're going to pay it way before you need it, starting in your 50s. And you're probably going to pay that $200 a month for a good 25-30 years before you even start thinking about nursing homes. So yeah, you're going to pay a lot of money into the system before you start receiving it. Many insurance agents and financial planners are steering clients to new hybrid coverage, basically life insurance with a rider. So essentially saying, and this has some problems as well, to say, hey, you got this life insurance, but if you come disabled, we'll pay your life insurance out at 80% so you can cover your long-term care. Well, why did you buy the life insurance? Because you have beneficiaries. If you spend it on yourself, then don't the beneficiaries need the money? You know, you can't have to question why that would ever work. We have no way of knowing if these policies will self-destruct in the future. Is that the actuarial job you want? It's like, man, if I mess up on my job here, this whole company goes under. Well, I can find a job somewhere else, right? And then that's true, but you know, it's kind of a. But throw on top of that the Human Genome Project. What does that do? Have y'all heard that thing before? Gene splicing and these machines that do all this analysis, and with these superconductor computers, this is just amazing time consumption, right? You got to do all this stuff, but once we get faster and faster, we have a test that can tell whether someone has a high chance of Alzheimer's. Would you take that test? Would you want to take that test? Would you want to know that? So there's a good video. I wish I could find this video. It was so excellent. I cannot find it. It was on PBS. This lady took it in her 40s and discovered she had more than 80% chance of having Alzheimer's. Guess what she said after the test? Boy, I'm sure glad I took that test, or boy, I wish I didn't know. She was saying, boy, I wish I didn't know. It really, really, the fact that she's like, man, first of all, what am I going to do about it? Now, you know, I'm going to wait until that happens. Can I really prepare? She's like, you know, now that I think about it, there's not really much I can do to prepare for it. Maybe it's just some dietary things I can do, but I was kind of doing those anyway because I knew my family had this issue. So as tests become more accessible, more and more people are saying yes. Well, what does this law say about the insurance industry? You can't use these tests to screen people. Well, what's the insurance company going to do if their customers can use the test, but they can't? That creates a massive problem, doesn't it? So if you got an 80% chance of dying in the next 5 years, and you know it, and the insurance company doesn't, you might buy a good $500,000 policy, wouldn't you? That's kind of what we're looking for here. So these can be ordered online for a few $100s. Insurers fear that without equal access, they will lose out the savvy customers. Consumer groups, on the other hand, fear that if underwriters have access, people with bad genes will not be able to buy coverage. Either way, the scientific advances are, you know, they're moving too fast. Unlike diagnostic genetic tests, predictive ones are conducted on people without symptoms. A person at increase of dying young may want to buy life insurance. Someone likely to contract cancer may buy cancer or health insurance. But predictive tests, unlike diagnostic ones, often need not be disclosed. The customer can secure in advance. So if you get a cancer screening and you know you have a high chance of cancer, you're not going to be able to keep that off the application for health insurance or life insurance. But you may be prevented by law, the insurance company may be prevented by law from asking you these questions. So adverse selection recently reported on a woman who bought long-term care insurance after detecting positive for that gene. Asymmetry of information. Now, we said on paper 1 and on paper 2 that the asymmetry was on the industry side, right? Now they're saying the asymmetry is on the customer side. The customer has more information than the insurance company. For life and health insurers who want to keep people alive and well, such information may be invaluable. Regulations today often protect consumers from mandatory disclosure predictive tests, but the rules are patchy. In America, the Generic Information Non-Discrimination Act bars health insurers and employers from using such results, but is silent on other types of insurance. So they may say life insurance can use this for life insurance, but health insurance and long-term care can't use it. So it depends. This is stuff that's regulated by the state. So there's 50 rules out there. So you don't really know until you look in which state that you are in. So yeah, it's the other thing in that PBS special. I may have told y'all this story, but I'll tell you again, though I thought it was interesting. Boy, that's an interesting name. I just noticed that. Jonathan Broomberg. Boy, just think if you got a job at Bloomberg, how interesting that would be. The poor guy would never get an email. They would all type it wrong. Anyway, sorry, I got distracted. But in this video, this lady goes in and she gets a genetic test because she's worried about heart disease because it's running in her family. And they show the two doctors looking at the tests and they say, no, the heart test was fine. However, this lady has a high probability of getting Alzheimer's. And then the doctors are sitting there discussing, do we tell her or not? She didn't ask for that. I mean, what do you think you would do if you're a doctor? If someone came in for a test for hearts, you now know they're going to have Alzheimer's. I would say you can't tell them, right? If they didn't come in for that test, not everybody wants to know that. And so the next scene, this lady walks in and she says, doctor, with the issues I've had with my heart, would that affect my memory any? Because I'm having some serious memory issues. Now what do doctors do? They tell her. So we did this test. I mean, she's kind of opening the door to them. I still don't know. I mean, if that's an ethical issue. And so this lady, she was glad to be told. So she goes to her sister and says, sister, you need to have this test. Her sister says, there's no way I'm taking that test. I don't want to know. So this is really, really tough stuff. So yeah, the industry's got to figure this out. The scientists, they don't care. They're just moving as fast as they can. So they can tell, eventually you're going to tell you what year, day, month you're going to die on. They can give you the probability of something happening. They don't know if you're going to die in a car wreck before it, but if you know you have an 80-something% chance of getting Alzheimer's, that's pretty powerful information. Regulations today often protect consumers from this. I think we covered all that. All right. Any questions on that? Long-term care. One question you might ask your employer is if they offer it. There's AARP. They offer it from long-term New York Life. Comparing employer, group versus individual long-term. I remember when I was at UTSA, they provided long-term care for a while and then they just gave up on it. So it's like, yeah, well, I think we'll do this. And they're like, no, we're not going to do this. I think you're going to find it's going to be really tough to get long-term care from your employer. I just don't think, think about it. Employers hate health insurance. Why would they open up this Pandora's box to long-term care? Why in the world would you do that? Because once you offer it and then the premiums start skyrocketing and you're covering 20%, 30% of the costs, what are you going to do? Cut back on it and then your employees are all mad at you. I don't know if I would touch this. Dave Ramsey approves long-term care insurance. So, he knows all this stuff. Is 72 old to buy long-term care? Yeah, probably so. Right? This is a lot like level term. You need to buy it young and spread it out so they can get premiums up front to cover at the other end. Once you get too old, it starts to get pretty expensive. Yeah, so ask. I think you're going to find it really tough to find. All right. So the next one, accelerated benefits. So some companies say there are times where we're going to pay your life insurance early based on certain triggering catastrophic events. So it's a living benefit. So essentially it's a rider that agrees to pay part, not all of your death benefit, who have some kind of illness, terminal illness, be custodial or nursing care. So it's limited to certain age time frame. And it's going to be more than your cash value. So the insurance company is throwing something in extra for you. So yeah, that could be beneficial. But again, if you have beneficiaries who need this money, then essentially you're taking that away from them. What are we assuming? Once you turn 65 to 85, you probably don't have beneficiaries anymore other than to cover funeral costs and those kind of things. So we're not going to give 100% of your money to you, but we'll give a percentage of it. Now, this brings up something that's really critical that you should definitely pay attention to. So I was dealing with the life insurance policy this last year. It was a horrible policy, but the person that was insured was in really poor health, so we kept it going. But the cash value was practically zero. So if we just stopped paying the premiums, we would have gotten almost nothing, like $200 back. You would never do that, all right? Never, for an older person, someone over 60, never just let the policy collapse. So what you need to do is go out and find a viatical company. And they have calculators online. And they're all in place. Now, I'll warn you, if you use their calculator, you will be getting a phone call within the next 24 hours. I have this one guy who's been calling me every 3 months, and I keep him calling me back because I'm actually really interested in this whole thing. I wasn't going to sell my policy to him, but I was like getting information from him. But these are great companies. I love them. So what these companies do is they say, hey, instead of surrendering your policy, sell your policy to us. So for my particular case, the policy was a $145,000 policy on someone not very healthy. They would have given me probably $50,000, $60,000 on it. So what should you do? You got a policy with a $200 cash value and you don't want the policy anymore because the premium went from $350 to $1,600. What would you do? Would you surrender that policy? No. If you can sell it to somebody for $50,000, get your $50,000. $50,000 is better than $200. What does the life insurance company say? Well, you're getting ripped off. They shouldn't pay you 50, they should be paying you 60,000. So what do you tell the life insurance company? It's like, well, you're going to give me 200. They're going to give me 50. There's no way for me to get 60. So why don't you give me 60 and you buy the policy from me, but otherwise leave me alone. Right? They're probably right. You probably are getting less money than you should, but it's the only other option you have. I would go for it. And they're aggressive. These are very aggressive companies. Insurance companies hate these companies. They'll ask you all kinds of questions on certain types of forms. Hey, are you a viatical company? Are you filling out this form because you bought this from somebody else? But you can go out and do your own calculations and see what they might pay you. The person who is being insured, they do want all the medical information on that person. This is a case where they're doing a medical screening not to see how healthy you are, but to see how unhealthy you are. So they want as unhealthy people as possible. They're not actually looking to win on every policy. And I'm sure viaticals hire actuaries, right? I don't know any actuary works for viatical, but I'm sure they hire actuaries, probably pay them pretty well. They don't have to win every time. They just have to win on average. The same way with life insurance companies. They don't have to win on every policy. They just have to win on average. So it's probably a very, very good business for them. And my guess is they probably are pretty profitable. I don't know any that I could show you the financials for, but they're probably pretty profitable. I don't know how they're regulated. I doubt that they're regulated like an insurance company. They don't feel like an insurance company, but they're interesting people. So essentially they buy the policy from you, and then when the person dies, essentially you're guaranteeing them to pass the proceeds on to them. So essentially they've kind of loaned your money and you're going to pay them back with the proceeds from the policy. So if they lend you 50,000 and the death benefit's 150,000, you're going to pay them the debt off with $150,000. All right, so never surrender a policy on anybody over 60 without at least trying that. There are some articles I gave you. Some of these might actually be interesting for paper 2, but this is the end of life issues. How do you handle people that are terminally ill? The right to death, kind of right to die kind of issues. So some of those articles might be helpful to you. All right, real quickly, group insurance. Most life insurance, we're going to do group life. Most group life insurance, is from large employers, and most of you will have it from large employer, but most life insurance is sold on an individual basis from a size of the policy. So you may have a $200,000 policy that you buy yourself, and your employer provides you a $70,000 policy. So most of your insurance is going to come that you buy yourself. But a significant and growing portion is sold on a group basis. Obviously, health insurance is predominantly group. Almost all group life insurance is term insurance. You're not going to get permanent insurance. The face tends to be lower for group policies than for individual policies. So what's the key with a group policy? This is true for group life, group disability, group health. You have a group contract. So the contract's not between me and the insurance company, it's between my employer and the insurance company. So there's one contract covering a large number of people. That's called a master contract. The employees supposedly receive a certificate of insurance. I don't know what that is because I don't remember receiving one. I'm sure I got something that maybe it's my little card that I get for the health insurance. These are usually experience rated. So they look at the group, and if the group has unusually high claims or unusually low claims, they're going to change that. That's based on the credibility, how much of the pricing is going to be based on that group versus how much can be based on a generic group. Group underwriting, unlike individual, there may not be any evidence of insurability required. So as long as you sign up during open enrollment, you're covered. It's a lot like the Affordable Care Act, right? As long as you sign up during the open enrollment, they're not going to ask you anything about pre-existing conditions. If the coverage is requested at some other time, what are they thinking? They didn't sign up during the open enrollment and then something bad happened to them. Now they're asking for the insurance. They're going to assume there's something bad. So then they are going to underwrite. Or if you ask for extra, I forget, I think USA covered us 1 times pay, might have been 2 times, 1 times pay, but you could buy 2 times pay or 3 times pay or 4 times pay. But if you bought the higher amounts, then you had to be underwritten. Because who's going to buy the higher amounts? The people that are sick and need the insurance. So group underwriting wants to ask, why does the group exist? They need to exist for some other reason than to buy the insurance. And then how stable is the group? And the stability of the group is really an issue of the cost of managing the program. The termination of benefits can vary. There's different options they have. Who's eligible, who's not eligible. Are part-time employees eligible? So what benefits are going to get? The premium payments can be contributory or non-contributory. Insurance companies prefer non-contributory. So if your employer is paying 100% of it, like with my life insurance from USAA, 100% was covered by USAA. The insurance company doesn't worry about pre-existing conditions because everybody's going to buy the policy, the healthy and the unhealthy, so you have good distribution. Or if it is contributory, they might want to say, hey, at least 70%, 75% of your employees have got to buy this. Otherwise, we know only the sick people are buying it. Administration can be handled a lot by the employer to take some of the costs off of the program. Prior experience, as we said, might have some influence on this. Usually what insurance companies hate, this is not true just about group, but a lot of insurance companies hate it when you shift carriers, because they usually think if you're firing this insurance company and hiring this one, and we know our rates are about the same, there's probably something you did that other company that you're trying to get away from, and then we need to research that a little bit more. The size of the group, small groups can be more expensive and maybe less reliable. One thing they need to know in the group is the age, or 2 things, the age and the gender of the group. So they need to know the ages and gender and they're going to use that against their mortality tables or their health tables or whatever. So that's the most important. So that's what you have to send every year. And if the industry that you're in, that has some implications for, what kind of claims they might get.
Has that changed recently? Because there's more people identify themselves differently. So
I don't know how they're handling that. Yeah, I have no idea. That would be an interesting topic to research. And I don't know how that affects someone's life expectancy either. So yeah, I'm sure actuaries are dealing with that, right? There's probably a paper on the actuarial exams about that somewhere. I have no idea. Yeah, I've been out of the field too long. Okay, contract provisions. The benefits are scheduled. It can be related to salary or whatever, how many years you've worked there, those kind of things. I won't go through this. You can read through those, but there's different ways. For me, I think what I had was probably pretty common. 1 times pay is probably pretty common approach. Again, we talked about eligibility. Beneficiaries, you got to denote who your beneficiary is. What happens when you terminate? If the employee terminates, they're no longer eligible, or if they go part-time, they may no longer be eligible. If the insurance company or the employer terminates, then the employees just lose their coverage. If the employee fails to make the contributions, then you're going to be terminated. But if you leave the job, you may still have life insurance. So group life allows you to convert your individual policy into a whole life policy, usually not into another term policy. The conversion is usually not very good, so very few people do it. And because of that, it's kind of a circular thing. It's too expensive, so you don't do it. So who's the only people that do it? The people that are about to die, which means the premiums are going to go higher. So even fewer people. So at the very end, only the very, very sickest are going to convert. And so it's not going to be a good conversion. All right, so this group, you're going to have group insurance. Group life, you won't spend any time thinking about it because it'll be free and you'll just have it. You're not going to turn down free insurance. I'm not even going to ask you. You're probably going to spend most of your time on group health, right? You're going to sit down with this complicated plan, have to figure it out. And at USA, what USA was really worked out well for me because I came to UTSA and I got full health care at UTSA, and USA said, hey, if you'll cancel your health insurance, we'll give you $2,000. I said, okay, that's fine. So I canceled my insurance at USA. They gave me $2,000 and I just picked up my insurance at UTSA. So that worked out really, really well. It's like, can I cancel anything else? All right. Other types of insurance, key person life insurance can be really, really critical if you have a firm where they have one employee that's just critical to the firm. Maybe it's a partnership and you have 3 partners. If any of them die, it's just going to take the whole partnership down. Key person life insurance can cover and really save that company. Maybe they can hire, maybe it's an engineer or some kind of programmer. And if that person dies, you get a $1 million policy. You can hire another engineer that has the same background and try to save the partnership. And then this is a really strange one. Coley, Boley, Toley. Corporate-owned life insurance, bank-owned life insurance, and trust-owned life insurance. Very, very bizarre coverage. But what this is your employer buys life insurance on your life, and when you die, the employer is the beneficiary. Seems to completely contradict insurable interest, right? It seems like your employer would really like for you to drop dead, wouldn't they? Say, this employee, they keep coming in late. We don't want to fire them, but if they die, we get $300,000. Like, hey, have you thought about smoking? What can we do to help you out here? Why in the world, when you see a firm doing something that just seems crazy, what are they doing? Taxes, right? This is all about taxes. Because what is life insurance? It's tax-free to the beneficiary. That's why they do that. The IRS hates this. They have fought it. But every time it's gone to court, the courts have ruled it that you can do it. The employers had to put in this to say we have an insurable interest on our employees. Losing employees is bad for the firm. We got turnover, so they somehow won that argument. It seems awfully weak to me. So it's essentially what they're trying to do is buy life insurance, whole life insurance. They pay the premium. It's invested in these securities that are making 5-6%. When the employee dies, they get the life insurance, which includes all the earnings they made on the policy, and they get all that tax-free. So it's essentially a way for them to make investment earnings tax-free. And that's why they do it. We were offered trust fund life insurance, and I did the analysis because when you look at the numbers, it looks really, really good. From a tax efficiency standpoint, it makes a lot of sense. But I had a huge advantage. I'm working for an insurance company. So I go down to Alan's office. Alan was one of the chief actuaries for a life insurance company. And not only that, he was selling a boatload of BOLI. And so I'm thinking, okay, this looks like a really great deal for me, but I got a subsidiary that's selling a bunch of this, and he's like got dollar signs in his eyes because he thinks he's making a fortune off of this. So it made me kind of nervous. So I go to Alan and say, what's going on here? So I sent them the numbers, and he looked at the numbers. He says, Ron, your employees are not, the people you're insuring are not going to die that fast. They're using a mortality table that is going to be much, much, much harsher than what you're going to actually experience. If you rerun the numbers with accurate numbers, the net present value is not good on this at all. And did he know that for sure? Yeah, because what was he doing? The exact same thing on BOLI. So yeah, he's like, this is a great product. And then we had a CEO shut the entire thing down because it wasn't USA customers. And he's like, why are you doing this? And he was so mad. He was lividly mad. But I trusted Alan, boy, that was a huge, you invest your finance majors. If you want to make a career in finance, find some way to interact with actuaries on the job. It will help your career a lot. They think about risk in a way that will really help you as a finance major. So yeah, I trusted Alan a lot. And so we just turned it down. We said, it's not going to be that good. It's not going to really work that well. But if the numbers they had sent me were correct, it looked good. But if my employees died 2 or 3 or 4 years later, it just was not going to work at all. So this is tax driven. And I think there's a lot of companies buying this and probably are not seeing the benefits that they thought they were going to get. All right, so are y'all ready to shut this class down and now start an entirely new class? You've been waiting for this. You can finally dust off your calculators and we get to do some pricing, all right? What you need to have open in the class is this mortality table. It's out there on Blackboard. See if you can find it. I think it's under miscellaneous class materials. We are using a very old mortality table, mainly because the newer ones got really complicated. They added a bunch of other bells and whistles that I don't care about, so we're going to keep it simple. This one works. This is a male table, so for men. I think it's a non-smoker table, so men non-smoker table. And it's a statutory table. So the people on this table die much faster than the average population, because the average population includes smokers, includes women, and this is a statutory table, so it's conservative. So anything I do on this table, especially when I get to my ideal product, my longevity product, it's going to look too good to be true, and there's probably some of that to that because that product does better when people die faster. I'm going to probably be showing people dying faster than they really will. All right, have y'all been able to find it out there? It's Kate. All right, so let's look at this table because we'll be using it a lot next class, and we'll do the lecture notes first, but then we'll get into the math. We have age. This actually should be attained age, but I've completely forgotten the difference between age and attained age. So one of you actuaries can figure that out and let me know. I used to know that. Does someone on the chat know that? Oh, I thought I was sharing everything, sorry. Is that better? All right, so attained age. So I don't know what attained age means. It means something to actuaries, but it's age. I mean, if your attained age is 52, you're 52 years old, but there's something else going on there. We have 4 symbols we're going to use: LX, PX, DX, and QX. The L's and the D's are number of people. The P's and the Q's are probabilities. Now, this table that I got actually started out, I think at 100 million or something like that. And it just on the exam, having that many digits, it just got to be too many guys. So I cut it down to 100,000, just make it a little bit easier to do.
So, like often you'll say if you've reached the age of 65, that means that you're gonna live this long away. So being the age like changes as you get older, your probability of dying. And,
Oh, that you're still alive at that age.
yeah, but the other one is just you're gonna pay these premiums assuming you opened it at this age and it might increase inflation.
So 65, and we'll talk about this, a 65-year-old has a longer life expectancy than a 25-year-old. Because they've already attained 65. So that makes, I still don't know the fact that they would use that in conversation, what distinction they were making. So it was a little tough for me, but I'm not as smart as actuaries, so I just have to kind of shake my head and smile sometimes. I had one actuary who's talking about people dying, people living, and he talked about it as if there was a third group. And I wanted him to keep going, like, wait, there's somebody else out there? All right. So LX, we're going to start with 100,000 people. How many will we have at the end? 0. We started with 111, 111 died. This table stops at 99. Now, I gave you some other mortality tables that are more recent. I don't know what the most recent one is. I never keep track of that, but it's CSO. We could probably find it. CSO latest mortality table. You can see what it is. They usually do it every 5 to 10 years or so. There's a not 2017 one. You know what SOA is? Society of Actuaries, right? Have y'all been to their website? Pretty good website. So yeah, so 2000, that may be the latest one. I don't know. I'm using the 1980s, so that I'm using a table before y'all were born. So you're not even on this table, but still I'm using this because for our purposes, we don't need accuracy. We just need to practice how to use the numbers. And if you look at the more current tables, you're going to find there's a lot more columns going on. So it's gotten much more complicated. All right. The people dying should add up to 100,000. You would think. Sure enough, it does. So we got 100,000 people dying there. This column will not add up to 100%, I don't think. And why doesn't it add up to 100%? Because the denominator keeps changing, right? This is the number of people who die divided by the number of people alive at the beginning of the year. So that can't add up to 100%, all right? And we know it can't because the very last number is 100%, all right? You're going to see that's going to be important in one of our calculations later. So you start off with 100,000, 177 die. The next year you have 99,823, 173 die. And what you notice here is mortality dropping, and it comes back up. So why does it drop? This is the middle table. We talked about this earlier. Shouldn't your chance of dying be going up as you age? But why does it drop between 25 and 29? Bad driving, right? So there's the driving. I saw an article today saying life expectancy in the United States has dropped pretty dramatically. I haven't read the article yet, but if I can get to it, we'll look at it. It's a good article to talk about when we're looking at mortality. So after that, every number is higher. There's not a single year where the number doesn't get higher. Right. So what we have to deal with are these formulas. We're going to come back to this discussion here, but these formulas. So what I do in the exam, and I might change this some this time. The first question on the exam is just you're dealing with these symbols. And it's the absolute worst part of the exam for most students. Mainly because we cover it now and you don't see it again until the final, and most students are like, wait, what is that? I don't even remember what that is. So this is a class, this next class, when we get in this, you may have to re-watch the entire class for the final because some students, it just doesn't come back. But we have these three symbols. LX is the number of people alive at the beginning of the year. That's real important. Beginning of the year. That's going to be our assumption, is that LX is the people alive at the beginning of the year, and DX is the people dying We say during the year, but we're going to assume everybody that dies exactly at the end of the year. All right? Why is that? Because it makes our life a lot easier. And it's also what the states require when you do reserving and other things. So if you're alive at the beginning of the year, if you die, you're going to die 1 second before your next birthday. Okay, so be careful. You're about to blow out the candles and you drop dead right before that. The QX and the PX are the probability of dying. So we're going to see that PX and QX have a relationship to each other. So some of these formulas that I'm giving you are simple algebra. You just move things from one side to the other. So if you understand the formulas, you'll have them. We're going to then take these formulas and we're going to actually price life insurance. That part of the class, most people do extremely well on the final. I have a few students that leave the questions blank. That just destroys them, but 80, 85, 90% of students get at least 80, 90% of the credit, and a lot of students get 100% on those questions. And you'll see why pretty soon, because we're going to do 1, 2, 3 products. You can say, okay, I'm kind of getting that, kind of getting it. And after a while, you can see, well, I'm kind of doing the same thing over and over again. I just got to know how many years am I covering them? Are they getting death benefits or living benefits? How many premium payers are there? How many years do they pay their premium? Once you get that down, the formulas are the same. It's just how many D's and L's are in the formula. So you'll see it's going to get pretty straightforward. So there's a part of the exam that students struggle with. That's not a big part of the exam. And there's a part of the exam more students do really well with. And then what I do, and we'll practice this, is I throw in a crazy problem. It's a life insurance policy that you would never sell in real life, but just to see if you can handle the math, right? I forget what it's worth on the exam, maybe 5 out of 75 minutes. The first time I did that, only one student got it right. It was not an actuarial student, it was a finance student. I know who she is, a lady named Dee Wu. She's now at Citibank, moving up fast at Citibank, so a smart person, but she figured out, the only one. Then I started working some of those problems in class. That first exam, I didn't tell them anything about it. I just said, there's gonna be a crazy problem on the exam. I was really impressed she got it right. I got gave a lot of partial credit. Then I started working them in class, and then suddenly, 40% or 20% started getting them, 30%, 40%. Then almost all the actuaries got it right, and maybe half the finance majors, that kind of thing. There were still a lot of students that just left it blank, which really disappoints me. If you're going to pay a death benefit to someone that's 92 years old, at least write D92 down. D92 times the face, you're going to pay that. You may get everything else wrong, but maybe I'll give you 5% credit for just writing D92 down. But some students just leave it completely blank. So that's one question you'll have. So this is a big chunk. This next exam is just heavy, heavy, heavy math, all right? So don't let this leave you. We'll practice a lot on this so you can get some practice with it. And then we'll start pricing the policies, which I think you're going to find pretty cool. We're going to do things somewhat longhand. There's 2 other symbols that the actuaries use. There's an M and there's an N. And what the M and the N's do is they combine the mortality table with discounted cash flows. We're not going to do that part. We're going to do discounted cash flows by hand. All right. So actuaries, I'll kind of get you partially there, and then you'll have to do the rest on your own. And I can't even remember how the M's and N's work. I took the FLMI exam, which I strongly encourage you to do if you're an actuary. Fellow Life Management Institution. One of the parts of the exam, I think there's 10 parts, and one of them is the actuarial part. And they actually do the M's and N's in that exam. I was really shocked. It was really great. I actually bought one of their books for that part of the exam because it really does cover things really, really well. So, but I can't remember what I had no trouble with it on the exam, obviously, because it's, it's just finance added onto a mortality table. But we're just going to do it by hand. I actually think doing it by hand makes more sense because then you can see visually how it works. So we'll stop there, but next class, bring your calculators or your Excel. All right, any questions on anything? Next Tuesday, we're going to stop about 10 o'clock. And anyone who's retaking the 3rd question will just have to stay until you finish it. If you're not taking the 3rd question, you can leave early next class. If you're on Zoom and you want to retake the 3rd question, you're going to have to come on campus.